So today's speaker is Dr. Patrick Hartley from the U of I, and he will be presenting today on agricultural lung disease. Welcome, Dr. Hartley.
Thank you very much for inviting me to present today. I apologize about the scrolling transcription of my voice here, having technical difficulties at my end, so hopefully it's not too distracting. So today, I don't have any disclosures to report. My goal today is to talk about agricultural lung disease, emphasizing some different ways we're thinking about it now and how that relates to our understanding of the bioaerosol and what may be inhaled in the occupational setting in various agriculture fields. As we think about the respiratory hazards associated with agriculture, I broadly think about them in a number of different ways. I am not going to address pulmonary or chest trauma, which is a significant issue in agriculture. Agriculture is a hazardous occupation. And, between tractor rollovers, entrapments, falls from heights, large animals that may not behave as we might like them to behave, and ranging from, gorings from bulls to being crushed. These issues mostly will present to our orthopedic and musculoskeletal colleagues and a part of a larger multiple trauma situation. So other than that little preamble, that's about as much as I'm going to talk about pulmonary trauma. I'm primarily going to focus on the inhaled injuries, the inhaled hazards, and some of their potential manifestations in the pulmonary system. Primarily the dust, the constituents of the dust, both organic, inorganic, and microorganisms, whether they are viable or non-viable. I'm not really going to address infectious processes, which in agriculture may be zoonoses that are transmitted from animals to humans, or other infectious diseases that one might encounter in an agricultural setting, such as histoplasmosis from disturbing the sort of guano or droppings of birds or bats or others. But just to be aware of those as potential respiratory hazards. When I think about the bioaerosol in agriculture, I'm thinking of both irritants and allergens. And when I see a patient, whether it's an individual in the emergency department that I'm asked to see, or in my clinic, or in the critical care unit, I think of both allergies and irritants. And then obviously the other part of the inhaled injurious milieu in agriculture is chemical inhalations. And I'll briefly discuss that separately. So allergens tend to be larger macromolecules with higher molecular weight. In general, they're capable of inducing an IgE-mediated immune response, and subsequent re-exposures of provoking an allergic reaction in previously sensitized individuals. So in the agricultural setting, that may occur from animal dander, pollens, and other mites and insect fragments that are that can in and of themselves induce an allergic response. Fungi, which we think about often in the context of farmer's lung or hypersensitivity pneumonitis, but in other areas as well. These all can serve as allergens. So too can some chemicals because of their molecular weight, or chemicals can be absorbed onto other particles and thereby serve as allergens. So organic dust, whether in agriculture and in other settings, tends to be a complex mixture of stuff, ranging from dust particulates, microbial cell wall components, and others that we'll talk about in a few minutes. It's estimated that in agriculture in general, that about 40% of these particles in the dust in the bioaerosol are within the respirable range. So usually less than 5 microns in diameter, about 1 to 5 microns in diameter. So these dust can penetrate the airway down to the terminal bronchiole and even the alveoli, where they can cause inflammatory responses. Some of the dust is obviously of larger particle size and will have more of an effect in the upper airway. And we'll talk a little about upper airway manifestations in a few moments. There have been some studies done in swine confinement buildings that shown that the respirable dust may be up to 60% of the total dust content in that setting, particularly in the finishing buildings where you've got the adult hogs that with lots of dander. There is a significant respirable dust component to that. Even within the respirable range, so of the dust that falls within the size, there is some studies showing that the particle size, even within what we would generically lump together as respirable, that particle size even matters within that. So there are further subdivisions of particle size that can matter, and I won't go into all the data on that, but there is some compelling work being done on that area. A lot of work has been done in the past 25 years or so, looking at the role of endotoxin in inducing airway disease in agriculture and in other settings. As you know, endotoxin is part of the cell wall of gram-negative bacteria, lipopolysaccharide. We've known since the mid to late 90s that in experimental models in mice and then subsequently in human studies that inhalation or injection of endotoxin induces an inflammatory syndrome, and in humans that can tell us the effects, the fever, shivering, arthralgias, and those of us that see patients with sepsis recognize that some of these are some of the prodromes that we see with leukocytosis and some of the other sort of inflammatory cascade that can occur. We also know from experimental studies that lipopolysaccharide administration results in a dose-dependent decrement in lung function, in airway function, and in diffusing capacity, resulting in airflow obstruction. These studies have been done in mice, looking at airway function and sort of everything from CTs to pulmonary function testing in mice, and obviously in humans. However, it's not all one-sided. So there is some controversies in the literature, and the level of endotoxin doesn't always correlate with the respiratory health effects in each industry, or even within the agricultural industry in each occupational setting. Some interesting work is being done looking at bioaerosols. Some of the first two studies are from researchers at the University of Iowa, looking at the microbiological burden of these and the spectrum of organisms in the bioaerosol, and ways of identifying which bacteria or fungi are in the bioaerosol, not just by culturing methodology in microbiology, but by some genomic sequencing. and whether that will shed some light on the etiology of disease or resistance factors that some individuals have, whether genetic or that can be induced. The third paper I've cited there, obviously as we think about the emerging hazards, and obviously we're just, have gone through a pandemic in the past 2.5 years of where do these pandemics arise in many situations, particularly as we think about avian influenza, the origins of COVID, whether it arose in animals and then jumped to humans. The biosurveillance of animals and the agricultural setting may shed light on emerging pathogens, and measuring the bioaerosol may shed light on it. This particular study is looking at novel influenza viruses and whether as an early surveillance. Switching gears a little bit, not just looking at the bioaerosol, but thinking about some of the chemical hazards that occur in agriculture, particularly in confinement buildings. The two I'm going to highlight here are hydrogen sulfide, so-called manure gas, which, we've all sort of recognized the smell at low concentration, that is the so-called rotten egg smell. But realizing that at higher concentrations, it causes olfactory paralysis, and that the concentrations that can result in significant health effects, including pulmonary edema, loss of consciousness, subsequent uncoupling of the electron transport chain, and asphyxia, it is odorless. And the medical literature is rife with sad descriptions of individuals, either in agriculture or in sort of working for municipalities, working in sewers or on pipelines, who have become overwhelmed by hydrogen sulfide and have died of occupational fatalities. And rescuers, whether those rescue initial attempts were by family members or co-workers, and then sometimes by EMS or the responders who have not had adequate respiratory protection. And frankly, that in the case of hydrogen sulfide usually means having a self-contained breathing apparatus. They have also become overwhelmed by the gas and have died in these incidences. So thankfully, with education and some preventive strategies, the number of these incidents has dramatically dropped in the past 30 years. But we occasionally encounter some of these tragic cases. Ammonia from animals sort of excreta, particularly urine, is a significant issue particularly in confinement buildings. Just to be aware that the threshold limit value for occupational setting is not usually exceeded in swine confinement buildings, but there have been a number of studies showing that at levels below that, which is the threshold limit value, that there are measurable decrements in FEV1. So the TLV is not necessarily protective of all workers in these settings, and better ventilation and other methods of control of these gases has beneficial effects, and obviously increase from the farmer's point of view of production as well. So let's talk about disease and clinical syndromes. So upper airway disease is common in agriculture. Rhinitis, both allergic and irritant rhinitis, sinusitis, and mucous membrane inflammation is pretty common in animal confinement operations. A number of studies done, some of the salient points that I pulled out was, of swine veterinarians, about 60% of them report rhinitis. In the agriculture health study, about 2/3 of farmers report rhinitis. A little over a third will report 3 or more episodes of rhinitis in the past year. Experimental studies looking at nasal lavage reveal a significant inflammatory response with increased neutrophils and inflammatory cytokines. There is data that appropriate use of a respirator, a fit-tested respirator, can decrease the pro-inflammatory response in farmers, but access to those respirators and fit testing and consistent safe use of those has been a challenge. And often at best you can hope for, if folks are going to use is to use a dust mask, most of the time. But consistent use, as one might expect in a different industrial setting, is hard to achieve in agriculture. While it's a huge, huge topic, I am not going to spend a lot of time talking about asthma in the agricultural setting. You're probably all familiar with the hygiene hypothesis and with early exposure to bioaerosols and endotoxin may be relatively protective against respiratory airway disease, particularly in children. But with the bioaerosol and the different types of exposures in agriculture, we can't make an assumption that the data would say that there is increasing incidence of asthma in some of these populations. In the agricultural setting, as in other settings, trying to differentiate between work-exacerbated asthma, in other words, individuals who have pre-existing asthma that has been worsened or aggravated by workplace exposures, whether they be irritant or allergic, versus asthma arising de novo because of an occupational exposure. Irritants may result in, particularly if a high concentration, may result in an acute airway injury, the so-called RADS, which is reactive airways dysfunction syndrome. Usually those cases are not difficult to diagnose. The person usually presents to an urgent care or emergency department with an acute airway injury, maybe in some degree of respiratory distress. Once they get over the acute injury, about 30 to 50% of those individuals who get RADS may go on to develop a longer-term irritant-induced asthma. By definition, RADS itself, you have to have the symptoms for about 3 months anyway to assign that diagnosis. So it's an acute airway injury, usually chemically induced, but in some cases a high dust irritant causes an airway injury, and it can be the entire airway. Sometimes they'll have laryngitis, pharyngitis, in addition to lower airway symptoms with wheeze, cough, shortness of breath, and then persistent symptoms that may last 3-6 months or longer. The other more typical, more common occupational asthma, either from low-dose irritants or allergic phenomenon in the workplace. So animal dander exposure, fungi, can cause an asthma-type syndrome. I'm going to spend a little bit of time talking about COPD, however. So there is increasing evidence, epidemiological evidence, implicating occupational and environmental exposures in the etiology of or contributing to COPD. While most COPD still is a smoking-related disease, in certain occupations, and depending on what study you read, up to 30% of COPD may have an occupational contribution. Those of us that work in occupational medicine will frequently get cases where somebody is a current or ex-smoker, seems to have lung disease that's perhaps disproportionate to their amount of smoking that they've had. And, we're being asked, is it due to the fact that they're a welder or work in some other setting? This is also true in agriculture. Again, the chemical inhalations, the bioaerosol, over time may result in airflow obstruction as measured by spirometry. Typically does not have the reversibility seen with asthma, and the clinical syndrome is consistent with COPD. In the dairy industry, a number of interesting studies have been performed. I'm just highlighting one of them from Macedonia, where so non-smoking dairy farmers were compared to non-smoking office workers. And the dairy farmers were known to have a higher prevalence of respiratory symptoms that we would at least associate with COPD, lower mean baseline spirometry, higher prevalence of diagnosed COPD, and there is an association between employment duration and the subsequent diagnosis of COPD in that population of dairy farmers. The agricultural health study that many of you may be familiar with followed a large cohort of farmers and their spouses. So looking for, often the spouse, sort of is very active themselves on the farm, either full-time or part-time, and shares many of the exposures of the head of household, whether that's male or female. This is a cohort from North Carolina and Iowa, and they were compared with the NHANES group. And in the agricultural population, they observed increased cough, phlegm, and wheeze. Apologies for the typo. Another study of Mexican immigrants in California, again looking at the FEV1 to FVC, or in this case FEV6, which is a surrogate for FVC ratio, was decreased associated with more years working in the agricultural industry in California. So this is just some or a sampling of some of the epidemiological evidence correlating COPD with working in agriculture. And in these studies, smoking was controlled for. However, I would caution that in some of the published studies, there are significant confounders. In some of these studies, particularly, these are small farmers, small farming operations that may be associated with lower socioeconomic status. So farm size is a significant confounder, and its association with socioeconomic status and the countries in which the studies are performed. So the devil is in the details with regard to some of the COPD data. On the flip side, there are some interesting bench data coming out that there are some not everybody who share, as we know, it's sort of, nature or nurture. It's the sort of our genetic background and interaction with the environment, that there have been some polymorphisms identified of toll-like receptors and nitric oxide synthase receptors that seem to be protective against airway disease. So again, it's not, and as we move forward, identifying these, as we do genome studies, and other studies will be helpful in understanding the etiology of airway disease and give us clues to prevention and treatment. So it's an exciting time to be in sort of agricultural sort of bioaerosol research. Now, the prototype agricultural-related lung disease is farmer's lung, which is part of the spectrum of hypersensitivity pneumonitis. Formerly called extrinsic allergic alveolitis, we don't tend to use that term much anymore. It's defined as an inflammatory or fibrotic disease affecting the lung parenchyma and small airways. There's some new guidelines that have been published in recent years. This one is from the American Thoracic Society, the Japanese Respiratory Society, and the Latin American Thoracic Society. And there in that guideline, they define hypersensitivity pneumonitis as an immune-mediated disease that manifests with interstitial lung disease in susceptible individuals following an exposure. Interestingly, they that the exposure may be identified or unidentified. And for those of you that have seen cases of hypersensitivity pneumonitis, you will know that in many cases we cannot nail down the specific precipitin antibody or the triggering organism or other sort of material that triggered this disease. Clinical presentation of HP is usually with cough and dyspnea, but sometimes other systemic symptoms such as fatigue, anorexia are prominent in cases. Most typically, the pulmonary function testing reveals restrictive physiology with reduced FEV1 and FVC, but a preserved ratio and reduced total lung capacity, and the diffusing capacity is typically low. That being said, some people do have airway obstruction. We do see air trapping because of the small airway component in hypersensitivity pneumonitis. So having a mixed pattern on PFTs or obstructive pattern only does not rule out the diagnosis if there are other features suggestive of HP. But most typically, it is a restrictive pattern. Certain farming practices increase the risk of hypersensitivity pneumonitis. There are studies from Europe and Asia looking at greenhouse farmers in particular, those that grow flowers, mushrooms, and usually it's the potting soil or whatever these are growing in. So it's not the mushrooms themselves that are inducing the HP, but the soil in which they grow that becomes contaminated and then aerosolized. The original descriptions of farmer's lung were primarily in animal feed or bedding, where it's, wet, inadequately dried, sort of densely packed, baled, typically hay or straw, that where these thermophilic organisms grew and then became aerosolized and sensitized the farmer or agricultural worker. So usually there has to be repeated exposure. You're not going to manifest HP on your first exposure to the organism, but identifying when the exposure occurred, how, and whether it was a large burden or low burden exposure over time that sensitized the individual. Typically, they are high molecular weight materials that induce the HP. However, there are some low molecular weight chemicals not so much in the agricultural industry, but in, what comes to mind is isocyanates that we more typically associated with isocyanate-induced asthma in spray painting in the auto body industry and in other settings. But isocyanates are low molecular weight, but have been described as causing hypersensitivity pneumonitis. In terms of the immune response, there is both the classic humoral with IgG precipitant antibodies, but also a Th1 cellular response. And what happens is then subsequently you've got a predominantly lymphocytic inflammatory pattern with loosely formed granulomas seen on histopathology. So they're not the dense granulomas that one might see with sarcoidosis. These are more loosely formed. The inflammation tends to be centered around the small airways, and hence that we may get not only the sort of ground glass infiltrates associated with the restrictive physiology, but sometimes also an air trapping and small airway disease component. I think I skipped a slide there. Excuse me, jumped ahead. So what happens is the one gets a sensitization, immune memory formation, and then with subsequent re-exposure, increased inflammation, and then in individuals where the disease is not recognized, they continue to have exposure, then it transitions to a more chronic fibrotic phase. And we're recognizing that more and more, that the importance of recognizing the fibrotic phase of hypersensitivity pneumonitis. How we classify hypersensitivity pneumonitis has changed over the years. The classical acute presentation with farmer's lung of an individual describing the sort of flu-like symptoms within hours of an exposure to moldy or contaminated animal feed or bedding. We don't see that much anymore because of improvements in animal husbandry, in farm practices with education and outreach from Extension Service and others. Subacute hypersensitivity pneumonitis can be hard to recognize, often misdiagnosed with bronchitis or pneumonia. And then the more chronic HP, which ultimately may lead on to fibrotic changes, is what we're all concerned about, because you may have lost ground that might not be regained in those cases. The classification I show here is by Hal Richardson, who's a former faculty member at the University of Iowa. He's since retired. The more recent classification that I alluded to earlier broadly categorizes HP into fibrotic and non-fibrotic based on the CT appearance, and with primarily based on imaging and some other clinical features. In the non-fibrotic, it is more likely that there is ongoing or recent exposure, and it may be possible to identify the cause. In the fibrotic, it may have been years since the exposure, and there may be cessation of exposure, which makes it hard to identify the cause because precipitant antibodies may be negative. And frankly, we don't have antibody tests against every one of the agents that can cause HP. And in this setting, the fibrotic, it can almost be identical to idiopathic pulmonary fibrosis or nonspecific interstitial pneumonitis. So teasing out whether it's HP or not can be a challenge. These are the references to the current practice guidelines with regard to HP. I've sort of alluded to this already, but hypersensitivity pneumonitis cannot be ruled out solely based on the presence or absence of the precipitin antibody test. There are a limited number of tests available to us. And we have to remember that a positive test is just a measure of, it just means that there has been exposure. Many asymptomatic farmers that do not have HP will have positive precipitins on a farmer's lung panel. In pigeon breeders, where pigeon fanciers or pigeon breeders' lung is another variant of HP, they have an even, almost half the pigeon breeders will have precipitin antibodies, but sort of less than about 20 to 25% may have clinical manifestations of disease. So in individuals where there is ongoing exposure and this clinical suspicion for HP is high, then it is helpful. And a negative test in that context may be helpful in ruling out the disease. But I wouldn't rely on it by itself. A closely related in terms of clinical manifestation syndrome is organic dust toxic syndrome, which is a variant of inhalation fever. An older term, mycotoxicosis, has been used to describe this, but the reality is that that most cases or many cases are not related to a fungal toxin. It is often related to lipopolysaccharide endotoxin from bacteria rather than fungal mycotoxins, although they can certainly be involved. The typical syndrome is there's a large inhalational exposure of organic dust. This is the classical sort of silo unloaders disease, where somebody is sort of, digging out the sort of nasty, crusty stuff out of the silo towards the end of the season, before the silo is refilled with again. And symptom onset classically is within 4 to 8 hours, typically a flu-like illness, malaise, myalgias, some chest tightness. Shortness of breath in general tends to be less prominent with organic dust toxic syndrome. Peripheral blood eosinophilia may be noted. Typically, the chest X-ray is normal, as are measures of pulmonary physiology, blood gases, PFTs, but that is not always the case, and I'll show you a case in a moment where the individual did have significant lung injury. Most typically, organic dust toxic syndrome is self-limiting. In some studies, it's been described, incidents of this have been described as high as about a third of swine workers report at least one episode of a syndrome consistent with this. And it's frequently confused with farmer's lung. So I'm going to describe a case. This is of a young man who saw, I think about 15 years ago, I think he was a patient of mine, who was cleaning damp, moldy corn from a grain bin. Within hours, developed fevers, arthralgias, but in his case, it's progressed over a couple of days rather than the typical self-limiting. He was seen in a local emergency room, had low oxygen saturations, provided with supplemental oxygen. Chest CT scan, which I will show you here momentarily. And you may see up in this sort of anterior that there's some small patchy areas of ground glass. I'll go back to the previous slide. He was presumed to have hypersensitivity pneumonitis based on his clinical presentation and was started on steroids. However, despite steroid treatment, he had a deterioration in his respiratory status, was transferred to the university. Fortunately, we did not have to intubate him. He was managed with non-invasive respiratory support with BiPAP. And eventually his symptoms resolved, probably in spite of rather than because of any of the steroids or antibiotics he was given, because he was treated fairly broadly once he had presented with respiratory failure. So his subsequent CT scan about 5 weeks later shows complete resolution of the infiltrates. He had negative farmer's lung precipitants, and all his airway cultures, blood cultures, everything was negative for bacteria and fungi. The interesting thing in him is that, by the time I saw, my colleagues in the ICU had treated him. I saw him a couple of months after his hospitalization. He had had additional exposures, even though he had been warned against it, to, again, damp, moldy corn, and did not have a recurrence of this symptom, of this syndrome, which would make one think that it was probably not hypersensitivity pneumonitis. You would have expected him, if he was immunologically sensitized to the mold, whether it was fungal or thermophilic bacteria, that he would have had the same or even a worse syndrome. His PFTs, once he got over the acute illness, were normal, did not reveal any restrictive physiology. So when I saw this guy, I thought it was more likely that even though there were some atypical features, that he had the inhalation fever, the organic dust toxic syndrome, and it was less likely that he had hypersensitivity pneumonitis. The atypical feature in him was that he did go on to develop some degree of acute respiratory failure with pulmonary infiltrates, which is not typical for this syndrome. But again, it just highlights sometimes the challenge that one gets into with, is it this inhalation fever, which should be self-limiting, and for which the individual has not been immunologically sensitized, or is it HP, farmer's lung, and do I need to give counseling to this individual that they should not do that type of work again, or that they need to modify how they do it because they risk getting progressive decline in lung function. So the guidance and occupational advice that we would give the individuals may be very different depending on this diagnosis. We would probably tell either the individuals, whether they had farmer's lung or organic dust, to wear respiratory protection in that setting in the future, although but other methods of dealing with the hazard should be tried first. The more generic interstitial lung disease it's not all about hypersensitivity pneumonitis. There have been a couple of studies published in the last 10 years or so, looking at the incidence of idiopathic pulmonary fibrosis in agricultural settings. Farming in this multi-center study that I've cited, the odds ratio of somebody describing farming as their occupation is 1.6, and in particular for livestock, it's even higher. In a larger meta-analysis that included the study above, agriculture or farming as an occupation has an odds ratio of 1.65 for a diagnosis of IPF. And again, livestock exposure, when they tease that out a little bit, seems to have a significant association. Well, this is less of an issue here in Iowa. the other interstitial lung disease consideration in the agriculture industry is pneumoconiosis, particularly in dry climates where there's lots of dust. And that pneumoconiosis presents as it does in the industrial or mining industry, with shortness of breath, perhaps with cough, patchy macules or nodules seen on X-ray. The problem is that it's often not thought about in the agricultural setting. But there have been a number of studies looking at this, particularly in California among Hispanic field workers. And this particular study cited is an autopsy study where they found higher prevalence of chronic bronchitis and small airway findings and of frank pneumoconiosis compared to in the non-farming population. And they have an odds ratio of almost 5.4 when they controlled for age and smoking. And just the caution is that in dry climates, that sometimes the mineral dust levels in the air, particularly on those windy, dusty days, can exceed the regulated occupational exposure limits. Significant silica in some of these areas, but not just in California, but in other places around the world where this has been described, such as in South Africa. Briefly, I'm going to just talk a little about cancer. There is a lot of conflicting data in the literature with respect to lung cancer in agriculture. And I've just cited a couple of studies below that have, there's two studies here that I cite that both look at the agricultural health study that I've told you about earlier in North Carolina and Iowa, that, pesticide in male applicators seem to be associated with an increased lung cancer risk. And when you use the exposure days as a surrogate for the burden, the occupational burden of exposure, but yet when the same data set was looked at differently, there seemed to be a decreased lung cancer risk in poultry and livestock production, and whether that is due again to the one could speculate. One of the speculations is, almost like the hygiene hypothesis. Does the immune response, because of the bioaerosol in, whether in confinement buildings, this is with poultry, or in sort of feedlots with livestock, does that redirect the immune response differently that is relatively protective against lung cancer? We don't know that yet. Since I mentioned silos earlier, I'm going to just briefly mention silo fillers disease. So we mentioned the silo unloaders disease a while ago, which was organic dust toxic syndrome or farmer's lung in that context. But silo fillers disease is due to inhalation of oxides of nitrogen that are formed as nitrates are converted to nitrites in recently ensiled plant material in a silo. So that when the silos are being capped off, if somebody enters the silo in the sort of days to 1 or 2 weeks following that, there may be significant levels of oxides of nitrogen in that space above the material. Particularly in where there's silage in silos, less so with corn because of the way it's managed, but it does happen. The symptoms reported by the individuals, typically they describe shortness of breath, feeling choked or smothered. Whether the full syndrome develops is going to depend. It's a dose response. Flu-like symptoms may occur, but then cough, chest discomfort, shortness of breath. They can be a biphasic response, which, if a case of Silofiller's disease is suspected when somebody presents to an urgent care or emergency department and with a classic history of entering a silo in the days or after it being topped off. If the person seems initially to be doing okay, be very careful about discharging that person home, because sometimes they can have a rebound over the next 12 to 24 hours and can develop an acute lung injury with non-cardiogenic pulmonary edema. And in the more chronic cases where this has happened repeatedly, or even as a consequence of the acute injury, they may develop a constrictive bronchiolitis, which is also described following exposures to these reactive nitrates or oxygen nitrates. My second case is such a case. This is a 71-year-old male that we saw back in, I think it was 2004, I think it was this case. 71-year-old male, classic history, had worked in a silo, developed respiratory symptoms, and within 12 to 24 hours of this. This was his initial chest CT scan with sort of alveolar infiltrates, ground glass infiltrates, patchy bilaterally. His chest X-ray, this was taken about a month later. So he had been discharged. He did okay in hospital, was supported. He was treated with steroids, however. There is not good data that steroids change the outcome with lung injury from Silofiller's disease, but he was given steroids at the time in the ICU, and subsequently, with a view to tapering them. His chest X-ray about a month later shows some improvement. Not quite clear. Those on the right side, he's got a number of old rib fractures. That's what you're observing there as sort of his case. Excuse me, I'm just going to go back a little bit. This one here actually was the X-ray taken about a week after his acute presentation, shows some infiltrates. The X-ray that I just showed you, unfortunately this is jumping ahead on me, this was about a month afterwards, and the infiltrates are clearing. His clinical course, however, was, unfortunately, he developed a steroid psychosis. He ended up with a psychiatric admission because of the prednisone. Once we got him off the prednisone, and he was temporarily on some psychotropic medications and did fine from a psych point of view. And ultimately, he was managed with the typical sort of an inhaled steroid and beta agonist rescue inhaler for small airway disease, which he developed as a consequence of this. In the remaining couple of minutes, I'm going to talk a little bit about preventive strategies. And many of you have seen this. This is from NIOSH, about how we think about mitigating hazards in the occupational setting. As you can see in the left, the most effective is by eliminating the hazard. So, or substitute it for another product. So, and a classic example of that would be asbestos. We now use fiberglass and other materials for insulation. They have some hazards associated with them, but not the same as asbestos. Engineering controls would be next in the order of priority in terms of isolating or separating the individual from the hazard. So think of in animals husbandry, and where the feed is piped in as opposed to having to be sort of broken up and poured in by some agricultural workers standing over a feed trough and getting in a cloud of dust. Administrative controls, such as, work shift and trying to limit the amount of time that the worker is exposed to the hazard. And then least effective of all these, but often the one that we tend to gravitate to, and certainly that employers will do because it gets them off the hook for doing some of the other things, is using personal protective equipment. But that is really putting the burden back on the worker to protect themselves rather than the employer to engineer out the problem. And this is all relevant in agriculture as it is in other occupational settings. So when we think about this in agriculture, then some of the syndromes that I presented to you, not going back into the silo after it's topped off. Strategies to decrease or limit, hydrogen sulfide from manure pits, the agitation of the slurry and manure, and sort of rather than just doing it all at once and releasing large pockets of this gas that may have collected down in the pit. Ventilation of silos or confinement buildings, depending on the situation. Adequate drying of food or bedding material, for cut plant material before it is stored so that it doesn't become moldy. When sort of breaking down the bales to put them out for whether it's feed or for bedding, to perhaps wet it down. So obviously you don't want to wet it at the front end before it's stored, but at the time when it's being used to try keep the dust level down. Silage material, putting plastic sheeting over it so that it is not getting sort of the oxygen, it's not getting the oxygen that it needs for these organisms to propagate. Covering feed troughs, I mentioned sort of, the amount of dust generated when animal feed is put into troughs, and, whether just putting a dust cover over it. There have been significant inroads made in agriculture due to outreach from, sort of the universities such as Iowa State and the extension service, from the insurance industry, from occupational medicine, from researchers, and many others that have made significant inroads in decreasing the incidence of some of these syndromes that I presented to you already. And again, PPE is the final step, but as you think about the agricultural industry, what is the access? So if a respirator is going to be recommended, are they going to have access to respirator? What is the appropriate respirator? Is it a self-contained breathing apparatus? Is it a powered air purifying respirator? Is it an N95 or a dust mask? Does it need to be fit tested? Well, if it's truly a respirator, it should be fit tested if it's a filtering respirator. How is it going to, and is there access to fit testing resources in the community? And then how is the respirator going to be stored in the workplace? Is it a one and done disposable like a dust mask N95? Or is it a powered air purifying that's going to need to be stored away from where the dust is? Because otherwise you're just putting a dusty respirator on your face. So some of these strategies need to be thought through, and there are resources available to assist with that. And with that, I think I'm going to wrap up here, and if there's time left for any questions, I can take any questions from the audience. Thank you.